A new wave of clinical research has raised both scientific curiosity and public concern regarding the antidepressant use of ketamine, particularly in patients who are also chronic opioid users. While ketamine has garnered attention for its rapid and, in some cases, dramatic relief from major depressive symptoms, recent data now suggest a troubling divide in treatment efficacy depending on the neurological state of the patient. Specifically, findings indicate that while chronic opioid users show diminished responses to placebo-based therapies, ketamine retains its antidepressant effect. At first glance, this might seem like a victory for ketamine, but a deeper look reveals more complex and concerning implications. The central issue lies not just in ketamine's function, but in what these results expose about the underlying damage inflicted by long-term opioid use on the brain's natural reward and healing systems. Opioids such as morphine, oxycodone, and fentanyl, when used regularly, alter the brain's endogenous opioid system, a network that helps regulate not just pain, but mood, emotional connection, and motivation. Over time, this can lead to a blunting of psychological responsiveness, meaning that even the suggestion of healing or hope, which typically triggers real biochemical shifts during placebo treatment, no longer works as it should. This phenomenon was observed in a controlled clinical environment where individuals with major depression underwent treatment with either ketamine or a placebo. Those with a history of opioid use experienced little to no benefit from placebo interventions, pointing to a neurological rigidity or numbness that could have long-term implications for their mental health care. This disturbing finding suggests that a large subset of patients, those with chronic opioid exposure, may already be neurologically resistant to a significant part of psychiatric treatment itself. Placebo effects, while sometimes dismissed, are an essential component of mental health recovery, often amplifying the benefit of real medications and fostering a belief in healing. If opioids erase or greatly reduce this capacity, the consequences go beyond mere scientific curiosity. They represent a crisis in clinical psychiatry that has yet to be properly addressed. Although ketamine seemed to function normally in these opioid-affected patients, this should not be mistaken as a simple solution or even a reliably sustainable one. Ketamine's long-term safety profile remains poorly understood. Frequent use can lead to dissociative states, tolerance, urinary tract issues, cognitive disturbances, and potentially psychological dependence. More importantly, the temporary nature of ketamine's antidepressant effects, often lasting days or weeks, means that patients may find themselves caught in a cycle of repeated administrations without a long-term exit strategy. When layered over the already complex challenges of opioid use disorder or dependence, this creates a volatile and difficult clinical picture. The deeper concern is that healthcare providers may be tempted to view ketamine as a kind of universal rescue drug for patients who have failed traditional treatments, especially those compromised by opioid exposure. This is a dangerous oversimplification, relying on ketamine without addressing the root cause of placebo resistance, namely, long-term neurochemical alteration by opioids, merely treats symptoms, not the underlying neurological damage. Worse still, it may further entrench the patient in a chemical dependence model that leaves little room for psychological autonomy or sustainable improvement. These findings also raise uncomfortable questions about how many antidepressant clinical trials may be inadvertently skewed by the unmeasured presence of opioid use. If some participants are fundamentally less capable of experiencing placebo effects or medication responsiveness due to prior drug exposure, the integrity of the trial data and its application to the broader population comes into doubt. This could have a chilling effect on how future studies are designed, forcing more rigorous screening and stratification of participants, and possibly excluding those with complex medical histories who arguably are most in need of new treatments. The growing popularity of ketamine clinics, many of which operate with minimal regulation and questionable oversight, adds to the urgency. Patients with coexisting opioid use or histories of substance abuse may be especially vulnerable to the seductive promise of rapid relief, but without adequate psychological or medical support, the risks multiply. There is little safety net if ketamine loses effectiveness over time, or if it triggers adverse reactions that compound the patient's existing struggles. In summary, While the current findings provide compelling insight into ketamine's ability to bypass opioid-induced placebo resistance, they also shine a harsh light on the silent damage opioids may be doing to the psychological systems that enable healing. The solution is not simply to funnel more patients into ketamine protocols, but to reckon with the broader implications of how opioid dependence reshapes mental health treatment from the ground up. If we fail to do so, we risk substituting one form of chemical dependency for another and leaving some of the most vulnerable patients with nowhere to turn.